Thank you for your introductions. Today, I'm talking about the current trend in minimally invasive therapy for cervical cancer. I'm the chairman of board trustee of our page. And also we have a MOU with the ISMIMUS. So I think it's a trend for the minimal invasive surgery and the non-invasive therapy. And our page is a well-known society. And 2019, we have an annual congress in Chongqing, China. More than 3,000 participants attend this wonderful congress. And year 2021 in Japan, but because of COVID-19, we have a webnet meeting and also more than 3,000 participants in this congress. And 2 years ago, 2022 in Taipei, that is after the COVID-19 is a very successful annual congress. And last year's 23rd annual congress in Singapore, thanks to the Berners Chant holding the wonderful annual congress, more than 1,000 participants in this congress. There are so many new innovative the knowledges in this congress. And this year will be the annual congress in Chennai, India, in 30th October to 1st September. Welcome you to join us. And also our wonderful journal, GMIT. The impact factor is 1.2, and I hope all of you can submit your paper to this wonderful journal. So we know that cervical cancer is the fourth most common cancer in the world, and it's a burden for the global. And so they happen in the low and middle classical income countries. So the competing the health needs impact the social economic conditions, healthcare infrastructures. So we know the cervical cancer is caused by the HPV virus, so it should be preventable. It should not be caused so many and attentions or so much money in the treating this disease. So we know what to prevent cervical cancers and what is the best way to treat cervical cancer. Because the HPV infections identified as the primary cause of cervical cancers, maybe more than 99% of cervical cancers, we can find they have HPV 16 or 18 infections. And the persistent infections with high risk HPV can lead to the integration of the viral DNA into the host genome, disrupting cell processes and promoting oncogenesis. And the oncoproteins E6 and E7 produced by high-risk HPV types play key role in inhibiting tumor suppressor proteins and also promoting the cell proliferations and disrupting the cell cycle control, ultimately contributing to the transformation of the normal cell, cervical cell into the cancer cells. So they have another risk factor, just like smoking, immunosuppressions, and multiple sexual partner, and poor nutrition, and the genetics factors include the individual's susceptibility to HPV infections. And early detection is very important because in early detections, we can have proper interventions. And most of the early stage cancers, cervical cancers, is often asymptomatic. So routine screening play a very important role to identify the precancerous lesions and early stage cancers. And also timely detections, we can have appropriate management strategies such as surveillance, treatment, or preventive measures to prevent the progression of the disease to the advanced stages. And the screening guidelines and strategies include pap smears, HPV testing, and the colposcopy is the acetic acid, glucose, iodine, and the screen and treat approach. Sometimes we can have a diagnosis and also have to treat the patient just like a leap. We can have a treat spontaneously with the detect about the precancers or cancer. The current treatment approaches, traditional methods include surgical treatment, radiation treatment, and chemotherapy. And the surgical methods include minimally invasive therapy or open surgery. And we know surgery is cornerstone for the cervical cancer treatment. And also, we also know it's very effective in control the disease and the improve of patients' outcomes. And also, the radiations in the advanced stages is very efficacious. And in chemotherapy, sometimes we need to combine with the chemotherapy to have a decrease the recurrence rate. And recently, they have advanced in cervical cancer treatment, include HIFU. And HIFU have shown efficacies in treating precancerous lesions. And also the immunotherapy, and include the targeted HPV oncoprotein. We can use vaccines or checkpoint inhibitors and adopt T-cell therapy. And we also know the therapeutic HPV-16 special vaccines have shown very efficacious. And also we can use the immune checkpoint inhibitors, ICIS, and tumor infiltrating lymphocytes, TILs. They also demonstrate improved clinical efficacies in cervical cancer treatment. And the target therapy inhibits molecules, typical proteins, specifically expressed by cancer cell to control the growth and the spread. And we also note after surgery or maybe in chemotherapy, we can use the chemotherapy with radiations or with the immunotherapy or target therapy to enhance the treatment outcomes. And also we know they have a promising result from the combination different therapeutic approaches in other cancer. And so it can be improved the cervical cancer treatment outcome. So we call it, what is the proposed intervention? Open surgery, or we should do the minimal invasive surgery. Before 1993, the first generation surgery, maybe open surgery is adequate. But after 1993, laparoscopic radical surgery began. So maybe that is a second generation surgery. Laparoscopic, maybe the proposed the treatment. And after 2010s, the laser surgery, robotic surgery coming out. So maybe that will be a good way to do the cervical cancer surgery. And maybe later on, no surgery or HIFU microwave, they have a good method to treating the cervical cancer. So from history, we note in the early stage, 120 years ago, Williams have the radical surgery, and also 1921, Okabashi have a radical surgery, Okabashi method. And after the 2062, the Laura Palmer have using the scope to doing the tumor sterilizations. And 1989, the Heinrich have the first laparoscopic hysterectomy. And in 1993, Nazar, Carmen Nazars, and also Keru, Daniel, and I, myself, and Dr. Huang perform the first laparoscopic radical hysterectomy. So the radical surgery should be from abdomen or from the minimal invasive therapy. Until the 2018, that is the nightmare of the minimal invasive cancer surgery. The publication of the Lake trial, they found the minimally invasive radical hysterectomy for the early stage cervical cancers have a poor outcome compared with the abdomen radical hysterectomy. The 4.5 year survival is the 86, and when compared with the open surgery, is the 96.5%. And also the minimal invasive therapy have the higher rate of the local regional recurrence. And they propose the potential reasons for the inferior oncology outcome is because of the using of the uterine manipulator or effect of the CO2 insufficiency. But I think Confucius has said no to 4 issues. There was 4 no's: foregone conclusions, subjective predeterminations, obstinacy, egoisms. So after the Lake trial published, the European Society have a survey for the cervical cancer treatment. We can find 48.9% the pre-leg study, they have using the minimal invasive therapy, but in 2020, after the leg study published, they just have a 18.2% using the minimal invasive therapy. So have a markedly decrease in the using the minimally invasive therapy. Should we objective predetermination? So we survey the data from the published the papers year 2000 to 2019. They have 13 studies, and we found the mode of the laparoscopic surgery did not affect the negative cancer factors, and of which drive adjuvant therapy. And in the minimal invasive therapy group, intra-op complication is similar, but they have significant post-operative complications. And in the minimal invasive therapy, they do not increase the recurrence rate or decrease the survival. So we know that disease-free survival is the core value for cancer treatment. So we found the paper is to focus on the size and the site in minimal invasive therapy. So they don't standardize the surgery. No proficiencies in the surgeon, maybe some of them still in learning curve, and the inadequate resections, especially in the parametric areas, and the careless of the tumor retrieval. And they had just 1.1 cases per center in 1 year in laparoscopic radical hysterectomy clinical trial. Cannot proficiencies label. And so we have also published our data in the past from the 2009 to year 2014. And we can find in our patient, 69 patients, we frequently doing the surgery. So the operation time just about 3 hours, and the blood loss just 250, and the hospital state 2.8, and the total lymph node at 18.3. Break training 2.4 days, and follow-up totally we have a follow-up more than 5 years, and in average will be the 96 months, and there were no recurrence and no days, and the 5 years survival will 100%. So here is our measure to get the laparoscopic radical surgery as a probed the measures. First, we insufflation from umbilicus, and after we can increase the intra-abdominal pressures up to 20, and the insertion from the deform point. And after insertion, the deform point, the intra-abdominal pressure decreased to 15. And then exam of the liver, diaphragm, abdomen, and the intestine. Then we doing the lymph node dissections. Because he is not a point, so we just doing the complete lymph node dissection, and then coagulate on the uterine artery, and then do the both sides of the pelvic lymph node dissections. Then we do the radical surgery. Because we can early detections of cervical cancers and standardize of the radicality technique, so we can have a good outcomes. And also we have a tumor-free concept, and we use the advanced therapy, the instrument. We can find we use the ligature, so very effective even in the uterine artery, IP ligament, just 1 or 2 bite of ligature, they can complete hemostasis. And also we removed the lateral side placopian and dissect the ureter tunnel and identify the anterior placopians. Here is the lateral placopian, and also we identify the posterior placopian, and also the anterior placopian have identified. After that, the adequate the margin have been separate and remove the uterus completely from below. After that, we have the molecular irrigations of the pelvic cavity. So if they have any leak, the cancer cell, they can be washed out. Recently, we have a closure the vaginals, so the probability of the cell cancer leak is quite rare. And the adjuvant therapy in tummy, also the qualified surgeon in the minimal invasive surgery is necessary. So lastly, we can find the hypoglossal nerve preserved and the splenic nerve also preserved, and it's a nerve sparing radical surgery, and all the pelvic we can examine is quite clear, and also is also standardized. So should not obstinacies. So the RPH have a statement on leg trial, and we announce we hold different opinions, and the surgeon capability is very important, and the standardizations for the radical surgery is crucial for the radical surgery, and the instrument we should use the advanced good instrument, and also we don't suggest to abandonment of the procedures because we need more study. So we propose a new clinical trial mitral study. And also in the Denmark, they have from the National Cancer Institute, they have a 1,125 in 10 years periods, 530 underwent the traditional surgery, and 595 underwent the minimal invasive therapy. And they found now in the after 2016, totally they have a complete transit to the minimal invasive therapy. But they found the outcome is the same. So they have conclusion about after the national database, they found robotic minimal invasive therapy in cervical cancer is oncology safe, and leg maybe have a select by us to the Danish national adoptions of the robotic minimal invasive therapy completely transitioned the surgical approach for early stage cancer since 2013. So abandonance of the procedures based on the single randomized control trial may be premature. So in Denmark, they have completely transitioned the surgical approach for the early stage cervical cancers to minimal invasive surgery already. So how can we have a good result? We should make this feasible in the laparoscope oncology surgery. We should use the Li-Fan point so we can have full hand surgery. We use the ICG, so we just needed to sampling the sentinel lymph node, and we equipped with advanced endoscope 3D or 4K endoscopy, even robotic surgery. And we standardize the procedures and having intimate the knowledge of the tumor-free concept and the equivalence of the advanced surgical instruments. So could minimal invasive complete transition the surgical approach for early stage cancers to minimal invasive surgery? Yes, we can. So the trend will become the minimally invasive surgery. So we make conclusions. The surgical trend is changed. The current trend is the minimally invasive surgery will be the trend all the time. And the minimal invasive surgery go on in cancer surgery, and the Danish national adoptions of robot minimal invasive surgery complete transition the surgical approach for early stage cervical cancers since the 2013. And our group, Li-Fan team, 100% minimal invasive surgery in the endometrial cancer, cervical cancer, and early ovarian cancer since year 1996. So we can do this. You also can do it. And the HIFU vaccinations may be play a role in preventing of the cervical cancers. So let's have a more focus on the minimally invasive surgery, HIFU, and maybe vaccinations. Minimally invasive surgery maybe combined with the chemotherapy and the radiation therapy, immunotherapy, or tachytherapy, maybe have a load in enhanced treatment outcomes. If we just doing the surgery, maybe sometimes it's not good enough. The adjuvant therapy include the immunotherapy or tachytherapy, maybe it's quite helpful for the enhanced treatment outcomes. So we advise you keep up the pace with the arpege, hold the line with arpege. Lastly, I invite you all to the Chennai, the annual Congress in this October 30th. Welcome you to here. Thank you.